I'm Daniella Kadian Dodov. I'm a vascular medicine specialist at Mount Sinai, and I'll be discussing medical management of pulmonary embolism. These are my disclosures, none of which are really relevant to this talk. And I thought I would just start with an overview of how we classify PE. So we think about massive or now high-risk PE as that with RV strain and hemodynamic compromise. It accounts for a high in-hospital mortality, with death common in the first 24 hours. Intermediate risk PE is RV strain without hemodynamic compromise, mortality estimates between 3 to 15%. And then low risk, which generally has an excellent prognosis when treated with anticoagulation and often can be treated as an outpatient these days. So when we think about our goals of therapy in PE, they're really twofold. So the first is to reduce this mortality risk by stabilizing the thrombus and preventing any further embolic events. And we can use anticoagulation or a higher level of therapy to do that. And second is to prevent the long-term complications of CTEPH. So this is older data looking at patients with a first-time acute PE, and at 2 years of follow-up, the CTEPH risk was about 3.8%. And recently, the FOCUS trial was published in the European Heart Journal. Same kind of idea. They took just over 1,000 patients with acute PE and followed them out to 2 years and assessed for CTEPH, which was present in 2.3%. The median time to diagnosis was about 129 days. And this post-PE impairment, which were symptoms of shortness of breath and chest pain and limited exercise tolerance, which was much more frequent in about 16% of patients. Okay, so how do we assess for injury? And what is kind of the rub with our therapies? So we know that the mortality without thrombolysis acutely with RV dysfunction is estimated to be about 1 to 5%. On the flip side, intracranial hemorrhage rates with systemic thrombolysis is about 2%. So what's exactly the trade-off that you're talking about there? Thankfully, we have some data to guide us in terms of assessing risk with different markers of RV dysfunction, whether that be echo or biomarkers, and they are incremental. So if you have both RV dysfunction and positive biomarkers with echo, your risk is higher than if you have just RV dysfunction or positive biomarkers. And this is now starting to make its way into the guidelines. We're not very good at telling how people do over the long term. This is data looking at over 200 patients with acute PE and RV systolic pressures measured on echo within 24 hours, and then at 6 months of follow-up. And in this study, 80% with pulmonary hypertension at diagnosis that were treated with anticoagulation alone normalized their RVSP on repeat echo, whereas an additional almost 1/3 of patients developed new pulmonary hypertension with NY heart association class symptoms greater than or equal to 3. So we are not yet good at identifying which patients are going to go which way. So the guidelines, most recent, are from 2019. They classify, again, patients into this high, intermediate, high risk if they have both RV dysfunction and biomarkers, or intermediate low if they have just one of those, or low risk. You can also use the PESI score, which is a clinical predictor using patient risk factors and presentation to determine the approximate 30-day mortality. If they're low risk, outpatient management is often possible. And in terms of managing the patient with acute PE, after you've assessed that hemodynamic instability and determined whether or not they're high, intermediate, high or low risk, your options for anticoagulation really are this, I would say. So you have unfractionated heparin for the higher risk patient who may require an intervention, low molecular weight heparin in this kind of intermediate low risk or low risk who's in the hospital, and then a DOAC for our lowest risk patient. And there is some data looking at an early switch to an oral agent. This was a multinational study looking at patients with about 400 patients with symptomatic intermediate risk PE with or without DVT who received a short duration of low molecular weight heparin or unfractionated heparin, and then were switched to an oral agent. The primary outcome at 6 months was symptomatic recurrent VTE or PE-related death, and 2% experienced the primary outcome. All of these patients were intermediate high risk. So pretty good in terms of efficacy. And low rates of bleeding. So 1 patient had a major bleed and about 16 had 1 clinically relevant bleed. Our oral options for anticoagulation are many, and I've summarized the major trials here for you. We have warfarin, which has been around the longest and is the cheapest, dabigatran, which is the direct thrombin inhibitor, and then our factor Xa inhibitors of rivaroxaban, apixaban, and edoxaban. I want to draw attention to this heparin run-in row because dabigatran and edoxaban used a heparin run-in prior to starting the oral agent, and it's important to keep that in mind if you're going to be prescribing that for your patients in hospital or after. Whereas rivaroxaban and apixaban had an oral run-in before transitioning to the maintenance therapy dose. There are some differences in renal elimination and whether or not you can use this in patients with a reduced GFR. So I would limit that probably to apixaban based on the data that we have available for patients with a reduced GFR or warfarin. And I want to spend just a moment talking about factor 11 inhibition because we're going to be hearing more about this as we move forward. And I specifically chose to focus on milvexian, which is the oral option that is being studied so far. All of these trials start in the orthopedic space where they look at patients after total knee or total hip replacement to see if they are good at preventing VTE. And so in this study, they looked at oral milvexian with either increasing BID dosing or daily dosing. This drug has a 12-hour half-life. Patients received the drug after total knee replacement for 10 to 14 days, and the other option was enoxaparin 40 milligrams. They all underwent venography for the evaluation of asymptomatic DVT. And what the study showed was that there was a reduction in the primary outcome of any VTE, and this was dose dependent for both the BID and daily milvexian. And it was lower than the rate that was seen in patients getting enoxaparin. The bleeding also was pretty provocative, I think. So any bleeding was somewhat increased, but clinically relevant bleeding was on par with, enoxaparin. It wasn't clinically statistically significant. There are some important exclusion criteria. You don't want to use these in patients with a reduced creatinine clearance, history of severe hepatic impairment, or in this case, they did not use it in patients with previous VTE, or any patient receiving any long-term antithrombotic therapy other than low-dose aspirin. Now, in terms of recommendations for acute phase treatment, the recommendations available suggest starting with anticoagulation, and this should not be delayed. And then for patients with high-risk PE, systemic thrombolytic therapy is recommended, or surgical pulmonary embolectomy, which you're going to be hearing more about. And so the PYTHO trial was mentioned. This was a randomized double-blind trial of just over 1,000 patients who had RV dysfunction by echo and or CTA and a positive troponin. So intermediate high risk. Patients received tenecteplase versus placebo and were followed. And what they found was that the primary outcome was reduced in the tenecteplase group, but this was really carried by a reduced level of hemodynamic decompensation rather than death. And this came at an increased cost of bleeding. So there was a higher rate of major extracranial bleeding and stroke between randomization and day 7, particularly hemorrhagic stroke. And this was particularly high in a subgroup of patients over the age of 75 years, with a trend towards less benefit when receiving tenecteplase due to this higher risk of bleeding. And so the bottom line is, in patients with intermediate high-risk pulmonary embolism, IV fibrinolytic therapy to prevent hemodynamic compensation comes at an increased risk of major hemorrhage and stroke, in particular for those older patients over the age of 75. So you really want to be cautious. This thrombolytic therapy has been looked at in the long term, so long-term follow-up from PYTHO. And this shows the rate of CTEPH and death in patients receiving either therapy with no difference in the development of CTEPH as assessed by RV dysfunction on echo. Patients had no difference in symptoms of mild dyspnea and functional limitation during follow-up either. So in terms of where we've thought about administering thrombolysis, we're hoping to reduce death, prevent recurrent PE, restore baseline functional status, and prevent CTEPH. In terms of withholding thrombolysis, we're worried about the long-term or major bleeding risk, and also the increased cost and prolongation of hospitalization. I think Dr. Goldhaber summarizes this very nicely in this editorial in saying that the long-term outcomes from PITHO really did not show at 2 years any reduction in mortality, any improvement in functional limitation, and did not reduce the confirmed cases of CTEPH or RV dysfunction as assessed by echo. So we really don't have the data to support its use for long-term outcomes. So in summary, rapid and effective anticoagulation is important in all risk PE, but the approach differs by risk. So you can use the DOACs for your lower risk patient, low molecular weight to DOAC for perhaps intermediate low risk, intermediate high, you think about low molecular weight heparin or unfractionated heparin, and then unfractionated heparin for high risk. There is a benefit for, or a role for systemic thrombolysis in patients with high risk PE when the risk of benefit of hemodynamic stabilization outweighs the risk of bleeding, particularly for those under the age of 75. And keep an eye out for this emerging data on factor 11. We're definitely going to hear more about it. And with that, I thank you.